Hopefully? Hello? Hello? Okay, I think it's working now. Awesome. Hi, everybody. It's me, Spectral Anomaly, second year med student, and I am here to study. We will be here to study. I'm gonna yap at everybody. Firstly, about antithrombotics, different kinds of antithrombotics. So, like, those medications like warfarin, Eliquis, um, all those. We're talking about that. But also, um, we will be doing a lot of other things. I'm also going to make sure that my stream is even on, like on my end, because I know I am live. Okay. But yeah, so sorry for being late. I had to eat food. And then I also had to set up a lot of bullshit on the side. Like my OBS stopped working for like a few minutes and I nearly crashed out. So that's what we're doing. That's what happened. What am I supposed to do? I can't do anything about that. So yeah. We're gonna get started pretty soon. I'm just gonna like yap for a little bit, warm up. We're gonna start off with I'm gonna start talking, and I will continue to start talking. Antithrombotic agents. We're just gonna continue talking for a little bit. I'm still trying to make sure everything is working on my end, as you know. I do my best, but obviously, I am simply a person and I am not perfect. Umbilices. But yeah, so this is what we're doing today. We're gonna like go over a lot of hemostasis and like the medications for hemostasis because like low-key, I'm sorry, but even though our lecture was okay and our professor was quite nice, I could not pay attention to Jack Diddley. I couldn't pay attention to Jack at all. It was very frustrating. I could not pay attention. So obviously, that's what this is for. I am learning, and we're learning together. So, I am also gonna do like some of the maintenance BS on my end. Like, so for Twitch, I have to do like a few little things here and there, etc., etc. Mainly in my stream manager. I'm just gonna wait for some people to join in. That way, it isn't just me talking forever. I'm gonna like probably. I think I'm down for to wait like a few more minutes, like maybe another minute, because I am gonna do like the pre-roll 3-minute ad. That way, it's out of the way, and then it'll allow us to do like 1 90-second ads after, so that it's easier. It should be easier that way, hopefully. Here's hoping. God willing, that kind of stuff. But yeah, I hope everybody's having a good day or good night, etc., etc. I mean, like, what else are we supposed to be doing here? Thank you, Cybernetic, for it. You're so cool. But yeah, so I'm also making sure that my drawing tablet is working because I am not going to mess up with that again. Because, oh my god, yesterday was so frustrating. Like, oh my god, like, what the hell was all of that about, Loki? Like, what? Legitimately one of the worst times ever, so we're gonna start off with 3 minutes, just so that it's out of the damn way. So we're gonna do this first, and I'm gonna like look at my monetization, because hopefully I can just turn off pre-rolls. Oh yeah, that's how I do it. I can just turn off pre-rolls. Beautiful. I think I figured it out. Awesome. Cool. it's going to be a little bit hard for me to see what's going on in YouTube chat, if there is even anything going on, which if there isn't, that's a-okay. There doesn't have to be low-key. I am very okay with just talking to Twitch. You know how it is. But okay, so I'm gonna, where is my lecture notes? My lecture note, like, little template thingy. There we go, lecture template, there we go. And then I can just turn on the grid lines. I'm gonna use different colors today. These two, so like purple and blue. So purple and blue today for antithrombolytics. But yeah, so if there's people in the other end, like on the YouTube side, hello everybody. Y'all, if you don't already know who I am, it's me, Spectral Anomaly, second year med student, VTuber, and this close to crashing out on a daily basis. But yeah, so did I not do the ad? I think I did it. Oh, it's not done yet. It's gonna be done in like a minute. Sorry. But yeah, so once that ad break is done, I have my water with me, and we are gonna be starting. It goes legit. What the hell was that lecture? Even. Like, it was very chock full of information, which I appreciate, but like, come on. Make it like a little less dry for me to pay attention to. Like, and here's the thing. The fucked up part is I love blood thinners. They're an interesting set of medications. He made them boring, which is crazy to me. Like, I was not prepared. I didn't know it was gonna be like that. I didn't know. I didn't fucking know, man. Jeez. But yeah, so we are gonna start once this bullshit is done. I hope wait, where's studio mode actually? Okay, perfect. It is working. Here's when I open up my Clip Studio. It should. Okay, cool. I'm gonna switch over to this. So we're gonna look at antithrombolytics. So basically, what are antithrombolytics in general? In general, what they are is they're fucking blood thinners. They make it so that you don't clot as easy. They can break. There are other meds that can break the clots up, but like specifically like blood thinners, they make it so it's a little bit harder to clot. And how are they gonna do that? We're gonna pull up the fucking like little picture, like the clotting factor, like cascade. So if you look at the clotting factor cascade, a lot of these different medications, they will act on different parts of this. So I'm gonna pull up the picture by Osmosis here. Like, we already know we're in medicine. Like, a lot of us are in medicine. A lot of my viewers are in medicine along with me. We kind of already know we already know what are thrombolytics, we know what blood thinners are, we know the clotting cascade, but there are different kinds of medications that can block the cascade at different parts of this. So, like, we have the intrinsic pathway here. Intrinsic is like, this is obviously the intrinsic pathway. The extrinsic is over here with 3 to 3A and 7 to 7A, and that goes into turning this into 10A. They're all like, everything meets in 10A. 10A. We got thrombin from V to VA, like 5 to 5A, 10A, all that. And then we have 11A, and then we have 1A, that's fibrin. And the stabilizing factor is factor 13 here. There are different coagulation disorders, which we already know about, like deficiency and like clotting factors. These can either cause excessive or inadequate clotting. So we have hemophilia A, B, C. Von Willebrand is at 7. Von Willebrand is at 7, and same with hemophilia A. Vitamin E, or E here, is a vitamin K deficiency. Also, wait, what? Kira, why are you here? I appreciate you being here, but you're a doctor. Ah! Hi, though. Oh my god. Thank you for the lurk. Y'all terrify me. Oh my god. Now I have to like really go my fucking A game. But okay. Oh god. What was I even saying anymore? Oh my god. But okay. Like, ah! Oh my god. Hi. You're on my VTuber wall. How are you doing? Are you at work or something? Girl, I can't teach you. You can teach me. What do you mean? What do you mean? Ah. Oh my god. What? Okay. Okay. Oh god, I hope I don't get it wrong. Shit. But like, so blood clotting, and normally it's just hemostasis is the physiological process by which bleeding stops and the final result is a clot. Like, that's the main thing. We got the stable fibrin clot here. That's what happens normally. But like, we have a lot of different shit that... You're at work being a real doctor! Oh my god! Also, how is work for you, by the way? Are you having a good day? I hope so. What even is the time for you? Like, I don't know your time zone. I know you're like UK, right? I don't know what it is, and I don't know what today is in UK time. Oh my god. But like, so there's like two different kinds of like hemostasis, or like the thing where you get the bleeding stopping involves two mechanisms. The primary is like, you got primary hemostasis is where you have like vascular bullshit, where you got like von Willebrand factor activation from like endothelial injury, the platelet thrombose, the platelet hemostasis, which is the adhesion, activation, and aggregation of platelets, which results in the form of the platelet plug, or the secondary hemostasis, which is what we're looking at, which is the activation of the coagulation cascade, which results in the formation of a fibrin clot. 11 a.m.? Oh my god. Wow. Oh wow. So you're like 5 hours behind me? Cool. Now I know. But okay, so for vascular hemostasis, I already said it. It's like endothelial injury, resulting in neurostimulation reflexes, and then endothelin release, which means that's where you get the transient vasoconstriction, leading to reducing blood flow and platelet accumulation at the vessel walls. Or if you have like the subendothelial, where you have the collagen, because collagen, like the tissue factor bullshit, that thing over there, that's where you get the circulating von Willebrand factor binding to the exposed collagen. Von Willebrand factor is that's VWF is VWF protein. That's what's synthesized and stored in endothelial cells and platelets in alpha granules, and it mediates platelet adhesion and aggregation, and it binds factor 7 and prevents degradation of factor 7. I think one of my chatters has factor 5 Leiden, but which is different, which is cool. Like, he told me about it. But oh god. Like we already we know what the hemostasis shit is, but like what we were like struggling to learn in class today was like the actual medications for it. So like I know a little bit about it, but that's just because like I worked with a lot of patients that had AFib or like that had AFibs or they had other things where they would bleed a lot. They would bleed really easily. So and they also had like cardiovascular disease, so they would also have to be on it because of like, you know, uh these meds are important, obviously. So yeah, we already know about the primary mechanism of hemostasis, but like let's actually look at the fucking medications here, because that was what we were having trouble with learning. So for a lot of these medications that I'm gonna be talking about, so like heparin, aspirin, warfarin, my beloved TPA, urokinase, streptokinase, TPA inhibitor, alpha-2 antiplasmin, or like the actual anticoagulants, like the actual okay. There's a really nice table in like one of our handouts that I'm just gonna drop into here. Like these motherfuckers. This is great. I love this table. Like the only thing I like about our class things is that they have really nice tables, like our class handouts and shit. This is, and like, but yeah. So we have the anticoagulants, which are the ones that directly inhibit thrombin. We have the indirect thrombin inhibitors. We have the vitamin K epoxide reductase inhibitors, which I hate. And we have the direct 10A inhibitor. So like rivaroxaban or apixaban. I like apixaban. We also have the antiplatelet drugs like COX inhibitors, so aspirin. We have glycoprotein 3 or 2B and 3A? Yeah, 2B and 3A inhibitors, so like abciximab or like tirofiban. We also have clopidogrel. Clopidogrel is Plavix, right? The funny thing is I only know a lot of these medications through their brand names. Which is funny. But like I don't know a lot of these medications. But yeah, so we're gonna go start off with the anticoagulants. So like a lot of anticoagulants were, well, all anticoagulants, let me just say. Oh! Wait. Am I live? Am I still live? What the hell, man? Are you kidding me? It died? I am so sad. I started talking already. Everything's cursed. It's all cursed. Is it better? Can you see? Am I back? Hello? Thank you for telling me. I had no clue until like I noticed something was off. That like my Twitch stats thing was no longer working. I was spooked. I was absolutely scared. I was like, huh? What the hell? What the hell happened? That was so weird. I didn't know it like completely died though. That happened to me like 2 days ago. I don't know why. But yeah. But yeah, anticoagulants. Anticoagulants mainly work by inhibiting the formation of fibrin clots. Where's my fucking, there it is. Like, that's here. They inhibit fibrin clots, or they inhibit the formation, so they can do it directly through directly inhibiting thrombin. So that one part of one part of the thing where it's here, is it working? But for real, is it working now? Oh my god, that's so annoying. Scuff is something that happens to me. It is okay. But yeah, so the actual thing for thrombin, we are back to here. So like I'm just gonna like name them as that. So the direct thrombin inhibitors are gonna be working here. Indirect thrombin inhibitors are gonna work a little bit higher on the table here. So heparin specifically. Heparin works in the blood to activate antithrombin factors, and those antithrombin factors inactivate several blood clotting factors. I really hope everything's working now, though. Legit. Yay! Yay! I'm so glad it's working now. Thank you, Kira. Thank you, Dr. Kira. Warfarin works in the liver, which inhibits the synthesis of several clotting factors. So, this motherfucker makes the clotting factors. This inhibits what's already made. This inhibits indirectly. Patch, you're a fucking coagulant. Also, wait, did it work? I really hope that one worked. Yeah, it did. Cool. You know what? So is bleeding disorders, Patch. So is bleeding disorders. What are you gonna do? Hit me? You ain't gonna do shit, man. What can you do? Now, on to direct thrombin. I already said it. They basically work directly to the antithrombins. They work directly to like turn off the what? Okay, please don't take my vaccines away. I will cry. Please don't take please do not take the vaccines away. That will make me sad. That is what will directly make me sad. Please no. Please no. Please no. We have a literal other doctor in here. We love vaccines. No thank you. Please. Please, I'm begging you. But okay. So what was I even talking about anymore? I don't even remember. So for treatment, we have different medications. So apixaban, we're gonna look at the anticoagulants. Yay! The most commonly used oral anticoagulant. I'm gonna talk about the oral ones. Let's not take away the vaccines. They're real. They're real. Please, no. Please. Obviously, vaccines are real. This is all jokes. This is all in Minecraft. This is all alleged. But okay, so the most commonly used oral anticoagulants, warfarin, are my beloved. Warfarin, how that works, it inhibits the vitamin K oxide reductase, which means you're gonna reduce the hepatic synthesis of the active reduced form of vitamin K, which then means you're no longer going to be having you're just gonna have less of like all the other fucking clotting factors. The cool thing about warfarin, even though I hate it, is the fact that it's very well known, it's super cheap, and you can directly reverse warfarin. You can directly reverse warfarin with prothrombin complex concentrate. Actually, Kira, do you how does it work when you're in the UK? Like, do you still use like a lot of the same meds? Like, I don't know like a lot of the indications like everywhere else, because like in the States, a lot of patients have to stay on warfarin because like it's not like we can really get on much else because it's expensive to like get apixaban or Eliquis or like any of the other cool ones. Oh, okay, cool. And but another advantage is that there is delayed reversal by increasing the production of vitamin K. So, but then again, like for me, that was the pain because like we would have patients. Oh, wow. Damn. I wish we had that. Mmm. I see. So, interesting. So that nobody gets Eliquis ever? Basically. Crazy. But yeah, the other advantage of warfarin, the vitamin K antagonist, is that it can be reversed by increasing your production of vitamin of like. What do you mean an EpiPen get cold? I like. I don't think it's. Don't store it like. What do you mean get cold? Bring it back in. Did you bring it back inside? Did you bring it back inside? Like, by... Do you have... You can't confirm you did? So, like, what... Wait. What's the temperature right now where you're at? Is it, like, negative... Is it... Like, by snow temperature, do you mean, like, 50? Do you mean, like, 5, 10, 0 C? Because, like, is there damage? Is your EpiPen damaged? 20F is... So... Oh! Oh! Shit. I would say talk to a pharmacist, maybe? Like, they should be... That's what they're kind of there for. Like, this is... Okay. This is what I would do. Like, I called, like, when my doctor wasn't around, like, he was busy at work, and I was not at work that day, because I was sick. No, you're good, you're good. Kira, question. What if you have... How long was your EpiPen, like, outside in 20F degrees? Yes. You may... So, Patch left it outside. Patch left his EpiPen in his car, and now it's snowing. Is the EpiPen ruined? I said you should talk to a pharmacist because I don't know for sure. That uh yikes. So, like, I don't know. I really don't know. It could be that maybe just get it warm and then just keep it inside, but, like, I don't know. Well, yeah, obviously, but, like, what happens if human error, you left the EpiPen in your car? Is it ruined? But okay, back to thrombin factors. So we got, like, the bigger trend. These will act directly on the thrombin. Thrombin is the enzyme, factor 2A, basically. So, like, 20 Fahrenheit. So that's like negative something C. And he left it like 20 Fahrenheit, which is like negative, like probably 10-ish C, I think. Yeah, I don't know. But the cool thing about direct oral thrombin inhibitors is that they're easily manageable when administered orally, and regular monitoring of the coagulation parameters is not required compared to like with warfarin. Because with warfarin, we had to do like regular PT-INRs. And apparently, and they also need for warfarin, you also need peri-procedural bridging anticoagulation. Yeah, wait, you're still on Medicaid? Are you still able to be on Medicaid? Because that is important. Needs. Oh, okay, good. That's okay, good. Look, lucky for you, because like when I was on state insurance, I still had to pay like, I paid like $32 for like my Adderall, and that would be like every month. So like, the fact that you don't have to pay anything for an EpiPen, crazy, and good for you, legit. Okay, so warfarin makes the factors. Warfarin inhibits the production of the factors. The issue with dosing warfarin is that you need PT-INRs dosing, and before procedures, once you stop the warfarin, you need to have procedural bridging anticoagulation. So like, you need a short-acting anticoagulant, like Lovenox is one, right? Lovenox is a good short-acting anticoagulant, right? Or maybe like a low molecular weight heparin. I know of Lovenox more than heparin, that's why I'm asking. And during the initiation of warfarin therapy, where low molecular weight heparin is administered. So, okay, let me rephrase everything I'm saying. So, during procedures, when you're on warfarin, you're going to need peri-procedural. That means during the procedure, like before that shit happens, you need bridging anticoagulation. So that's when you have a temporary admission of a short-acting anticoagulant, and it's typically a low molecular weight heparin. Though I also have seen Lovenox being used in that way as well. And it's used when anticoagulants need to be discontinued transiently, and during the initiation of warfarin therapy. When low molecular weight heparin, because this is what we're going to be talking about for that one, is administered in parallel with warfarin therapy, that is the During the initiation of warfarin therapy, you're going to be taking low molecular weight heparin in parallel with warfarin therapy until adequate anticoagulation is achieved. And with that one, more PTINRs. PTINRs for everybody. I don't like doing PTINRs. Legitimately, I hate them. But the issue with warfarin is that it's not suited for acute therapy of pulmonary embolism or deep vein thrombosis. I hope I got all that right. Okay, now we're gonna go back to what I was talking about earlier, which is dabigatran, or the other direct, the direct thrombin inhibitors. So the direct thrombin inhibitors, these are going to selectively act on factor 2A. These will act directly on factor 2A, selectively. So what the fuck does that even mean? Basically, the action of dabigatran and all these direct oral thrombin, like direct thrombins, these are going to directly bind to the receptor for it's going to directly bind to factor 2A and then like stop it, basically. There's other anticoags as well. The overview for that. Let me explain some of it. We're gonna get to that when we get to parenteral anticoagulation. I'm still on orals. Orals already. Hatch, what the fuck, man? Why do you always get hurt? Jesus Christ! Be careful! Fuck! The cool thing about dabigatran and the direct oral thrombin inhibitors is that they're easily manageable when administered orally, and you don't need to monitor their coagulation parameters regularly. It's not required. And antidotes are available in the case of life-threatening bleeding. For dabigatran, you can give them a monoclonal antibody, the idarucizumab. You can I'm gonna write it out instead because I'm not saying this fucking word. Antidote is darucizumab. Idarucizumab. Oh my god, you're amazing. Idazuzum? What? Idarucizumab. Oh my god, you're amazing. Thank you. Also, a lot of these medications sound like demons. That's why I only know them by their brand name. I hate having to know them by their not brand name. And apixaban and rivaroxaban, you can fix it with andexanet alpha, I think. Or, yeah. But yeah, so for these, I like these the most. They're just selective and direct inhibition of factor 10A. We love just directly going at factor 10A. I like monoclonal antibodies too. I don't like their names. I don't know how to pronounce them. I'll type it out. I know how to spell it. Don't ask me how to say it. You're gonna hear me suffer. But apixaban and rivaroxaban, you can fix it with antidote is andexanet alpha. Oh, so you like them because you're a sadist. I see. I understand now. Ah, I see. But no, for real, how the fuck are you supposed to say them? But okay, but I digress. The drawbacks for the direct oral anticoagulants, so dabigatran or the direct oral factor 10A inhibitors, they're all expensive. They're really new, so there's limited clinical experience with these drugs, but they are not recommended in patients with artificial cardiac valves. For cardiac valves, you unfortunately have to keep them on warfarin. So the real-line study for that, actually, there was a study on like the use of oral direct thrombin inhibitors. So there was this study in like 2013 called the Realign study, and this study showed that dabigatran causes more thromboembolic and bleeding incidences than warfarin in patients with artificial heart valves. The study had to be canceled due to the unfavorable risk profile. It was crazy. There are like but like let me yap on like some general notes on the oral oral anticoagulation. So for the indications for all these motherfuckers is prophylaxis of like basically preventing the formation of like a clot that's going to obstruct a blood vessel. So if you're at risk of having a PE or DVT, yeah, no thank you. If you have been like bedridden, you've had prolonged immobilization after surgery, you're gonna be put on one of these. Or non-valvular AFib. I've seen a lot of patients on AFib, I literally mentioned, that are on either warfarin or my warfarin, the one I hate, or like Eliquis, or Eliquis is a Pixaman. Eliquis is a Pixaman, right? I keep Eliquis. What is your brand name? Yep, it's a Pixaban. I have to stop gaslighting myself. But okay. There are expected laboratory changes when we look at these medications as well. So like if you've had a patient on warfarin for a long fucking time, you're going to see increased PT and INR, but there's no change to there's not going to be any change to the partial thromboplastin time or the thromboplastin time, and that's going to be routinely monitored. The PT-INR is what I have to do all the time. The direct thrombin inhibitors, you're going to have a prolonged thrombin time, but no change to PTT or PT. For 10A inhibitors, you're going to have prolonged PT and PTT, but no change to thrombin time. Yeah, sure. Ask the question also. Okay, so these motherfuckers. So I'm gonna like write all that in here. So lab stuff. For this one, you're going to have, as I said specifically, up thrombin time. Up PT-INR. No change to PTT or TT. That I think that's a Lev question. Where's Lev when we need her? Is she awake? For indirect thrombin, for factor 10A, we're going to have prolonged PT and PTT. PT, T, PTT, but no change in TT. Like, that's definitely, I think, like, low-key, that's going to be a Lev question, and I wish she were here to answer it. Also, like, technically, Kira is at work, so she might not get to you. But I can ask that of Lev the next time she's live. Like, that's definitely a Lev question. Yeah, no, like, Kira works. Kira, doctor. But yeah, so here's some mnemonics, basically. But also, like, some important side effects. The important side effect of like all oral anticoagulants is going to be a dose-dependent increase in bleeding risk. Dose-dependent increase in bleeding. For also for rivaroxaban and apixaban and adoxaban XA. That means they're all 10A inhibitors. So literally it says it right here in the fucking name. So XA. XA. XA, they're going to be direct 10A inhibitors. Okay. So we are gonna just do a really quick, we're gonna do a little quick Q bank on this one as well. So in 3, 2, 1, hopefully it'll transition properly. Studio mode, study. Yeah, okay, I can do the Q bank session now. So, questions should be working now. Okay, so an investigator is conducting a phase 1 trial for a novel epoxide reductase inhibitor with favorable pharmacokinetic properties for cerebrovascular accident prophylaxis. 2 days after the trial starts, a subject begins to notice pain and erythema over the right thigh, and it progresses to a purpuric rash with the development of necrotic bullae over the next 24 hours. The partial thrombin time is 29 seconds. Thrombin time of 28, and the INR is 2.15. Wonder what this could be, you guys. I know my other med student buddies are in here. They're not answering the damn questions. How dare they? It's... One second, let me look at the labs again. Oh yeah, no, everything's really long. So the prothrombin time is super long. PT INR. INR is a little high. Where's the INR at? Oh, wait. Oh, God. Okay, so the INR is 2.15. INR of 2.15 is... Yeah, these are all elevated. So this is just a warfarin XP, basically. So... Where'd it go? Damn it. Oh, epoxidized reductase. Okay. Okay, never mind. So, epoxide reductase results in the formation of reduced vitamin K. Of these vitamin K. Okay, which is essential for the activation of both procoagulant as well as anticoagulant protein C and protein S. Of these vitamin K dependent factors, factors 2A and 10A have long half-lives. Protein C and factor 7A have the shortest half-lives, and thus are the first components to be depleted following epoxide reductase inhibition. Despite an early increase in PT and INR, okay, so I was right that this is warfarin. I was just thinking of the wrong fucking factors. It's factor 8. Despite the early increase in PT and INR caused by decreased 7A, the patient is initially in a hypercoagulable state because decreased active protein C levels cause increased activity of 3A and 5A. This hypercoagulable state can result in intravascular microthrombosis, which causes the warfarin-induced necrosis. Look, see? It's okay. These aren't real patients. 71-year-old lady comes to the physician because of palpitations and shortness of breath. Okay. She has hypertension and congestive heart failure. Her pulse is 124. Blood pressure is 130/85. She has AFib. See the irregular rhythm with no murmurs. She also has a narrow complex. She has narrow complex tachycardia without P waves. And she is given a prophylactic medication that can be reversed with this medication that I cannot pronounce. I cannot wake them up. I am sorry. But we are going to save this patient. We're going to save this patient, which I'm very happy about. So, this is going to be direct inhibition of thrombin. Because dabigatran is the one that can be directly reversed by the one I cannot pronounce. It's G. The answer is G. The answer is G. Direct inhibition of thrombin is the mechanism of dabigatran, which is the oral direct anticoagulant. The effects of dabigatran can be reversed by the administration of the medication I cannot pronounce, idarucizumab. But TXA or tranexamic acid can be used if idarucizumab is not available. Hey man, it's okay. Could be worse. Could be worse. Ooh. Reduce levels of protein C. This is warfarin-induced skin necrosis. Hey, like... But hey, look, this one, it's another warfarin question. Because again, tender purple discolorations. Let's look at the first question that we saw. The key info. Purpuric rash with necrotic bullae over the next 24 hours. Obviously, the PT and INR are elevated in this one, so obviously this was warfarin. I just got the wrong part right here. I knew it was warfarin, though, which is pissing me off. But yeah, this one is dabigatran. And this one is another warfarin question. Tender purple discolorations. He began taking a medication after a failed cardioversion for AFib, but he can't remember the name. Most people are going to be given warfarin because it's just a lot cheaper. It's a lot cheaper. Everybody, they know what this medication is. They know how it works. It's old as fuck. So they know what this is. They know how to use it. Everybody knows. They know what's up. They know what's up. And now we have a 59-year-old patient coming to the physician because of left leg swelling that happened after a transcontinental flight. Ooh, she has a DVT. She has a DVT, you guys. So, her platelet count is okay. Her partial thromboplastin time, or the PTT, is elevated. Her prothrombin time is also a little elevated, but there's no change in the thrombin time. So this to me looks like a apixaban, a factor 10A inhibitor. Because again, with this patient, we're going to be seeing an elevation, or we're going to see a prolongation in the prothrombin and the partial thromboplastin time, but no change in the thrombin time. See, we are learning. We're learning somewhat. But okay, 68-year-old man with type 2 DM will come to the physician because of a 5-month history of episodic palpitations, dizziness, and fatigue. Oh, Jesus Christ, he's got AFib again. I think this is gonna be a... So, this to me looks like... It decreases the long-term risk of thromboembolic. Okay. I feel like it's either going to be... Oh my god. I didn't read the answer. It's D. It's D, not F. I knew which one. It was warfarin. But, like, I just wasn't reading the fucking choices. That's on me, though. But okay. 68-year-old man undergoes successful mechanical prosthetic aortic valve. After the procedure, he is started on an oral medication and instructed he should take it for the rest of his life and avoid consuming large amounts of dark leafy green vegetables. So, man is trying to not get as much vitamin K. So, which of the following laboratory parameters should be regularly monitored to guide dosing of this medication? It's going to be PT, INR. The PT and the INR. We love warfarin. I don't love warfarin, actually. I don't love warfarin. God, I don't love warfarin at all. Okay, a 66-year-old man with coronary artery disease and hypertension comes to the emergency department because of intermittent retrosternal chest pain. Oh! So, he smoked a pack of ciggies daily for 39 years. So he's 39 pack years. Okay, so this is probably going to be the irreversible inhibition of cyclooxygenase. So he's going to be put on a baby aspirin for the rest of his life, especially because of the history of coronary, especially because of the pertinent medical history with coronary artery disease and hypertension. So it's going to be what? Oh my god, embolic stroke. That's what they were worried about. I didn't read this part of the question. Damn it. It's gonna be C. Damn it. I was like, he's had 8. He's old. He's old, maybe it's aspirin. Oh well. But hey, guess what? 71% correct. Not too bad. Only 2 wrong. Okay. We're gonna go on to parenteral anticoagulants after I continue yapping about the oral anticoagulants. So we're gonna switch over back to the drawing board. So also, we are gonna go on to, like, I already talked about the general notes regarding the oral anticoagulation. This is the picture I was looking for, you guys. This is what I wanted to show you. Here, this. This is the picture I was looking for because I like this picture the most. But yeah, no, look at this. So, the first one up here. Ooh, wait, why is it darker on there? What the fuck? Give me a second. Hopefully it's a little better. Can you see it a little better? I hope so. But okay, so for the liver, we have the So for vitamin K reductase, so vitamin K antagonists, these are the ones that go into inactivate the epoxide reductase. So we're going to have less amounts of reduced vitamin K. That's how warfarin works. When we look at the extrinsic pathway, over here, we have the direct oral factor 10A inhibitors. Those are your apixaban, rivaroxaban. Those. We also have the low molecular weight heparin, the heparinoid, and the synthetic heparin also work active on AT3, which is also going to then inhibit this indirectly. This works here and then goes here. Direct oral factor 10A inhibitors literally just go straight to 10A. The unfractioned heparin is going to act on AT3, and it will also inactivate 10A, and also thrombin 2A. But the direct oral thrombin inhibitors, these are going to be the dabigatrans. But yeah, so we have the apixaban, we have the warfarin, and we have the dabigatran. Those are the three that we're thinking about here. I am gonna copy this picture and then send it over. One second, I'm also going to unhide that, put that up, put a new window right here. Cool. So we went through orals. We're gonna go into like a comparison of warfarin and heparin really quick as well. So but okay, so warfarin, I already said this is going to be, the comparison is going to be, this is oral. IV or sub-Q, that's the heparin. That's what the heparin is. Heparin is IV or sub-Q. I'm just looking at the routes of administration first. So ROA. Next, we're gonna go look at the mechanism of action. So the MOA. So warfarin is going to downregulate the synthesis of factors 2, 7, 9, and 10. So, or 10, 7, 9, 2. 10, 7, 9, 2. These are the procoagulants. And the synthesis of the protein C and S, which are the anticoagulants. So, protein C and S. The site of action for this one is going to be in the liver. That's the liver. You know what? I'm going to make this a little bigger. So we can already see the route of action for warfarin is oral, heparin is sub-Q, mechanism of warfarin is reduction of the synthesis of factors 10, 7, 9, and 2, which are the procoagulants, and also proteins C and S, which are the anticoagulants. And this is going to be done in the liver. I'm going to draw liver in here, that way we don't forget. It has a slow onset as well. So let's look at this. So the mechanism of heparin, how that works is it activates antithrombin, and which directly reduces the action of factors 2A and 10A. The site of action is in the blood, rapid onset with a shorter half-life. So the half-life for this one is going to be several hours, while warfarin has a half-life that is several days. So I'm going to make this a little easier for me to read. So that's going to be the mechanism here. So for this one, inhibition of factor 10A and 10A and 2A, this is going to be happening in the blood directly. So I'm going to draw some blood cells here. The time is going to be in hours. So this is going to be their half-life. It's a very shitty way to just kind of do it, but it'll make sense if you look at it. It makes sense, I promise you. I believe this makes sense. It has to. Because if it makes sense to me, it might make sense to you. Who knows? I'm gonna hope it does. I'm gonna make this a little easier to read. Antithrombotics. Hopefully. Is that a little more legible, you guys? Is that easier to read? Because I hope so. I hope y'all can read it. Okay. Okay, I'm gonna drop this into the general as well. By the way, I have a Discord now. If you do !DC, you will get a link to the Discord. Okay, the monitoring for heparin, you just have to do the PTT because this affects the intrinsic pathway, while warfarin, you have to do the PT or the INR because this affects the extrinsic. So warfarin's going to be mainly on the extrinsic, as we said, because it's 10, 7, 9, 2. Intrinsic is going to be still, it acts mainly on the intrinsic path. The heparin acts on the intrinsic pathway, while warfarin acts on the extrinsic. And the reversal agent is going to be protamine sulfate for heparin. Protamine sulfate, right? Yeah, protamine sulfate. I have to go back to my drawing so I can draw it. Protamine sulfate. Okay, I think this is a pretty good picture to snap, so I'm gonna take a screenshot of it. And here we go. I'm also going to delete that and put the new one in. Where'd the picture go? What the hell? But okay, so we are back in it once again. But okay, so the adverse effects though of like these medications, we're gonna go on to that really quick, right after I clear off my fucking board here. I'm gonna delete. Oh no, shit! I want to delete all this. I'm gonna lock that way it doesn't get messed with again, and I'm gonna delete everything else. So, what are the adverse effects, you guys? What do you think would be the adverse effect if you're gonna be taking blood thinners? Would you think increased bleeding? You would be right. It would definitely be increased bleeding. That is what happens. Increased bleeding is definitely something that's going to be happening. For all of these anticoagulants, you're going to be having dose-dependent increased risk of bleeding. Small wounds cease to bleed spontaneously, though, so no additional measures are needed. But severe cases of hemorrhage are usually going to be in the brain, GI, or retroperitoneal. So let me write that in. ADE is just going to be average drug events. So, this is going to be dose-dependent bleeding. Countermeasures for the extensive bleeding would be to discontinue the medication, so discontinue the coumarins, or the coumarins are like the actual class name for for warfarin, and like heparin. Those are coumarins. You can also administer FFP or prothrombin complex concentrate, or PCC, for rapid reversal of the warfarin effect, or you can give them vitamin K, though it will take longer, vitamin K1 specifically. But for a lot of these medications, for specifically warfarin though, there is warfarin-induced skin necrosis. So I'm going to write that in. So warfarin-induced skin necrosis. And it's seen within the first few days of treatment with high doses of warfarin. Because here's the thing, warfarin inhibits all vitamin K-dependent coagulation factors. And so, also, anticoagulants protein C and S, which are the ones also made by vitamin K, have a relatively short half-life and are depleted more quickly than the procoagulants 2, 9, and 10. So you're going to have increased factor 5 and factor 8 activity, which means you're going to have a hypercoagulable state, like while you're first taking the medication. And when that happens, you're going to have formation of microthrombi. You're going to have like tiny little clots. And these tiny little clots are going to cause vascular occlusion, tissue infarction, and blood extravasation. And This has increased risks in patients with underlying hereditary protein C deficiency. The presentation of this are going to be painful purpura, hemorrhagic blisters, and large areas of necrosis. And this will mostly be affecting the subcu fat tissue. So the prevention for this, though, is you're going to have temporary bridging anticoagulation with heparin until warfarin has started to act and the initial hypercoagulable state has been bridged, because that's why you have heparin on with warfarin at the same time. And also, individuals with protein C deficiency are at a higher risk of developing warfarin necrosis, as I already said, because if you already have very low protein C, you're gonna end up with like higher of the factor 5 and factor 8 activity. For direct factor 10A and direct thrombin inhibitors, still dose direct risk of bleeding. And that's it. Just dose-dependent risk of bleeding. That's the main one. General management, so you can give them TXA or tranexamic acid. You can also give them, there are interventional steps to stop the bleeding. But if life bleeding risk occurs, you can also give them PCC or protein C concentrate. Also, we're gonna go into heparins in a little bit because heparins are a lot. There are so many things with heparin. I still can't get my head behind them, honestly. But like, okay, warfarin and disc necrosis. I'm gonna put in needs bridging when starting. Needs bridging when starting with heparin. I actually don't know if Lovenox can be used for this as well. I feel like I can ask the Discord. But yeah, hopefully I get an answer to that pretty soon. Like, I'll find out. But yeah, so the indications for a lot of these anticoagulants are mainly going to be, for the coumarins, you're going to have prophylaxis of stroke in patients with valvular AFib or non-valvular AFib, patients with a heart valve replacement or heart failure, also for MI. The standard target for their INR for a patient with AFib is going to be an INR of like 2 to 3. 2 to 3, higher, but it's going to be higher in mechanical heart valves. It's going to be usually, like, instead of 2 to 3, it's going to be 2 to 3.5. It's also a good therapy, and it's also secondary prophylaxis for deep vein thromboses and pulmonary embolism. But it's also prophylaxis for thromboembolism in the following patients. So if like a patient had a total knee or hip surgery, or like a hip replacement or hip fracture surgery. While for dabigatran, or like for the ones that end in "an", so like the direct thrombin inhibitors or the direct factor 10A inhibitors, dabigatran or apixaban respectively, this is going to be for non-valvular AFib. But like because of the increased risk of stroke. That's like the thing. Also, I appreciate if you guys stick by for the ads. If you don't want to, that's a-okay. I'm not gonna make you. Like, what? What am I supposed to do? I'm just here having fun talking. What? The contraindications. So there are general contraindications for oral anticoagulants, mainly coagulopathies, also hepatic dysfunction because of the impaired hepatic production of coagulation factors. You're also going to have the risk of increased bleeding, suspected vascular lesions because you're going to have the increased risk of severe bleeding. If you have an aneurysm, if you have endocarditis, if you recently had a stroke, gastrointestinal bleeding, or if you had surgery. These are like the general contraindications. Also, if you have a tendency to fall risk is a big thing, especially like if you're old and you're gonna fall. If you fall, maybe something breaks, maybe you get bruises, you're gonna not stop bleeding. It's gonna be scary. So obviously no. If you're pregnant or breastfeeding, warfarin crosses the placenta, so warfarin is going to have teratogenicity and fetal bleeding, but heparin, low molecular weight heparin will not. Also, but if you're breastfeeding, it'll be fine. For breastfeeding, warfarin is not contraindicated, but they're not recommended. Oh wait, let me say that again. So the side effects of the oral anticoagulants during pregnancy and breastfeeding are unknown, so they're not currently recommended. Dabigatran, though, it has very specific contraindications. So if you have dabigatran, if you have concurrent administration of like ketoconazole, itraconazole, cyclosporine, tacrolimus, or dronedarone, no, you're not gonna be given dabigatran. So let me just write all this shit out. Everything that I just said. So, contraindications. Contraindications. So, these are going to be coagulopathies. If you already have acute bleeding. Or rather, if you're actively bleeding. Obviously, we don't want to give you a fucking blood thinner. Obviously, we don't want to give you a fucking anticoagulant. What? Are we crazy? That's you're gonna kill the fucking patient. My god. Ugh. If you have like an aneurysm, or if you maybe have your endocarditis, also bad. Aneurysm, severe arterial hypertension, endocarditis, recent cardiovascular events, or like maybe a recent CVA, surgery, GI bleed, GI blade. Tendency to fall. Or I'm just gonna say fall risk. I increased fall risk because it's gonna make it worse, and if you fall, it's gonna be fucky. But okay. For also, if you have already said it, severe renal insufficiency, concurrent administration of other anticoagulants, except for like heparin though. Like short use of heparin to maintain function of a central venous catheter, that's fine. Or like when you're changing from one pharmaceutical form to another, or like yeah, like very very important times for when you can. But so warfarin interactions, because we're gonna be talking about warfarin, because warfarin fucking sucks. I hate it to death. I know it's useful. It's useful for patients with. It's very useful for patients with heart valves, but I hate dealing with it. I care about it. It doesn't mean I like the medication though. It doesn't mean I like the medication. God, no. God, absolutely not. So, warfarin shit. It is metabolized by CYP. CYP 450, and its effects can be impacted because of this. So, decrease in anticoag. So for CYP inducers, you're going to decrease the blood thinning. You're going to decrease the anticoagulant effect because the medication is metabolized too quickly for it to like actually work. Also, foods rich in vitamin K can counter the effects of warfarin. Gastric acid inhibition, cholestyramine treatment. This is also going to impair the uptake of warfarin. The increase of anticoag effect. Wait. Increase in blood thinning. So, I'm gonna zoom in on this, that way it's a little bit easier for us to see, I promise. So, for increased blood thinning, antidepressants can increase your, some antidepressants, PPI, amiodarone, grapefruit, can inhibit CYP 450. Acetaminophen can also do that. Sulfonylureas or sulfonamides, they can also increase your blood thinning effect. The decreasing of blood, so here, here's a mnemonic. So increasing in blood thinning, it's going to be CYP 450 inhibitors. For decreasing the anticoagulant effect, we're going to be thinking alcohol. For increase alcohol. Phenytoin, phenobarbital, rifampin, griseofulvin, carbamazepine. All of those are going to decrease the blood thinning. phenobarbital, rifampin, or rifampicin rather. Well, let me rifampin. Rifampin, rifampicin, they're the same thing. What am I saying? But yeah, so St. John's wort, anything that are CYP450 inducers plus vitamin or like vitamin K, because vitamin K can, so it's a competitive inhibitor. If you get enough vitamin K in the system, you're gonna just reverse it. Vitamin K ingestion or administration will reverse the anticoagulant effects. So, the mnemonic I got for you from AMBOSS is chronic alcoholics steal fen, and never refuse greasy carbs. So chronic alcohol use, St. John's wort, phenytoin, phenobarbital, nevirapine, rifampin, griseofulvin, and carbamazepine. These are all going to decrease your warfarin levels, which also then decreases your blood thinning. Also, vitamin K just counters the effect of warfarin. While the ones that are going to increase the anticoagulant effect are going to be the sickfaces.com group. So sulfonamides, isoniazid, cimetidine, ketoconazole, fluconazole, alcohol, so binge drinking, like not chronic alcoholism, but like sudden binge drinking, Cipro, erythromycin, sodium valproate, chloramphenicol, omeprazole, metronidazole, and grapefruit. These are all CYP450 inhibitors. Additional considerations are going to be like for the bridging anticoagulation, the administration of heparin for the duration of the transient hypercoagulable state caused by heparin therapy, because heparin prevents coagulation by activating antithrombin, so you have the reduced risk of venous thromboembolism and skin necrosis, and it also can be used during interruptions of like warfarin therapy. But okay, next one we're going to do is we're going to go on to the parenteral anticoagulants. Yay! Parenteral anticoagulation. Okay. Oh my god, that does not look like words. Parenteral anticoagulation. Parenteral anticoagulants. So this is where we have the different kinds of heparin. We have unfractioned heparin. We have low molecular weight heparin. We got synthetic heparin. We have heparinoid, and we have direct thrombin inhibitors. So just talking about the heparin types is going to take a little bit. So give me a second. So we have U, F, H. We have L, M, W, H. I'm going to get another color for this. Let's go with a nice yellow, that color. And we also have synthetic. Oh wait, no. God, that's really hard for me to see. We also have heparinoid. Heparinoid. So we have different kinds of heparins that we could do here. So, unfractionated heparin. This is going to be given sub-Q, like for prophylaxis, but for therapeutic, like for therapeutic purposes, this will be given through IV. So, unfractionated heparin. Let's explain this. So, that's just straight heparin. Heparin neat, basically. Just think of this like if you're think of the heparins as like you're setting up a cocktail. What kind of how do you want your whiskey set up? So like, let's just think of this as heparin neat. Well, not a lot of you drink, so some of you might not get this. Some of you might not get what I mean, but like, so heparin neat. Let's say low molecular weight heparin, it's on the rocks. I don't know why I'm using alcohol for this, but I'm thinking about it. And then this is gonna be shaken. Shaken, synthetic. Heparinoid, like... Technically, heparinoid is like a glycosaminoglycan, though. So, like... I don't know what I'm gonna do for this analogy here, but like... I don't know, stirred? But okay, so we're gonna go back to the color here. So UFH. UFH is just straight heparin, basically. So straight heparin here, it's prophylaxis. It's going to be sub-Q, and therapeutic dose is going to be through IV. The antidote for unfractionated heparin is going to be protamine sulfate. I'm going to get the table up after I finish talking, so don't worry about it. But these are all indirect thrombin inhibitors. So, just heparin. Heparin is just an anticoagulant used in treating and preventing blood clots. We already kind of know that. But it's made of a mixture of sulfated mucopolysaccharides, which bind to the endothelial surface and various plasma proteins, and the activity is dependent on antithrombin. So, I already mentioned there are different types. The unfractionated heparin, this is like the regular fine molecular weight fraction that inhibits like multiple blood clotting factors, especially thrombin and factor 10A. Low molecular weight is going to be enoxaparin, dalteparin, and tinzaparin, and these have shorter chains. So it's like the length and weight of the chains are going to be like what it acts on more, just from what I'm understanding here. So I wish they would just give me a damn table of all these, but I mean, I'll just talk about it first. So the monitoring during therapy is going to be you're going to have to monitor their activated partial thromboplastin time, their APTT, their platelet count, and the clearance is going to be through the liver, and it's the preferred agent for patients with renal insufficiency. The antidote is going to be protamine sulfate. For low molecular weight heparin, this is going to be enoxaparin or dalteparin. This is going to be administered sub-Q, and the monitoring during therapy is going to be, you're going to monitor factor 10A, but it's not really recommended. Clearance is still going to be renal. The clearance for low molecular weight heparin is going to be renal, and it's contraindicated for those with renal insufficiency. That makes sense. And the antidote is going to be protamine sulfate. It's a partial reversal. There's also synthetic heparin, which is fondaparinux, which is going to be administered sub-Q, and you don't really need, it's not generally recommended, but in specific cases, you can monitor their anti-factor 10A activity. And the antidote is like activated prothrombin complex concentrate. Heparinoid these are gonna be a different kind of heparin, and basically you just monitor factor 10A, and the antidote is protamine sulfate. So we're gonna pull up the table here. Oh wait, it's the same fucking picture. But like, this is what I want y'all to think about whenever you look at this. Like, when you think of like the different kinds of things that work for the heparins, like, just remember this table. Just memorize this table. It's extremely important. That's what they're gonna make us memorize, so like, we might as well memorize this fucking table. Because the pharmacodynamics, we're gonna go to the pharmacodynamics while I'm just looking at this table, okay? So the pharmacodynamics of unfractionated heparin, firstly. Unfractionated heparin is going to increase the activity of antithrombin. It's an indirect inhibitor of factor 10A, because there's antithrombin 3 potentiation, which is going to lead to the inhibition of factor 10A, which means you're going to have decreased activation of prothrombin. TLDR, less thrombin means less fibrinogen activation, which means less fibrin. So, thrombin factor 2A. So, unfractionated heparin binds to antithrombin 2, or antithrombin 3, and thrombin simultaneously at 2 distinct binding sites. And antithrombin and thrombin held by heparin in close proximity. This is the complex formation, which means there's going to be increased thrombin inhibition and decreased fibrinogen activation, which means decreased fibrin. The anticoagulation effect quickly ceases once administration is stopped, which is why this shit is poggers. That's why this shit is poggers when it comes to like doing the bridging therapy. This motherfucker will like leave in hours instead of like in days, like warfarin. That's how this shit works, I promise you. But yeah, that's how that works. We're just going to keep looking at this table while I talk. So, I already said, the anticoagulant effects quickly cease once administration is stopped. Now we're going to go on to low molecular weight heparin. So, and the synthetics. So, what if I just pull this picture up, like, not like this? 1 second. I'm going to save this picture. I'm going to put this in my stream assets folder. So, anticoagulation summary pick, courtesy of AMBOSS. I love AMBOSS. I could never survive without AMBOSS. Legitimately, they are my favorite thing in the world, and I'm very thankful that I have access to them. So, we are going to open this up. I'm going to put this picture in. Okay. I am going to hide that. I'm going to put this down, put that underneath, decrease the size a little bit. I'm going to make myself a little smaller. Oh, sorry. Put on the filter, the 3D panel. Just going to have a little bit of wiggle There we go. So you already see where my hand is pointing. I'm kind of covering it. Sorry, but like, so unfractionated heparin that acts on AT3, and that's going to end up acting on 2A to inhibit it. The low molecular weight and synthetic heparin is also, and heparinoid, they're also going to act on AT3, and they're also going to go on to 10A. The thing that's different with unfractionated, though, is that it will also go and inhibit thrombin 2A as well, in addition. So if you inhibit thrombin 2A, you're going to not have the fibrinogen to fibrin transformation, so no clot. But the low molecular weight heparin, the heparinoid, and synthetic heparin is just going to go straight to the 10A. That's going to go mainly for the 10A. It's because of like size, I think. I'm pretty sure. So okay, yeah. The shorter chains will primarily inhibit factor 10. That's why low molecular weight and the heparinoid and the synthetic heparin, they have shorter chains, so they will inhibit factor 10 and less on the heparin, and less on the thrombin. What am I saying? And it is effective in treating thromboembolic conditions and have better bioavailability, so there's less frequent dosing needed, unlike with unfractionated heparin. Sorry, I just need to take a drink. Alternatively, though, but when it comes to the administration of heparin, the therapeutic range is going to be 0.2 to 0.4 units per mil. And it's like considered therapeutic for treating venous thromboembolic diseases. And it generally corresponds to a PTT of 1.5 to 2.5 times the base value. The PTT is not standard like the PT or the INR for warfarin, leading to variability between different reagents or instrument systems. When it comes to the toxicity, though, of heparin, we're going to get to that after the break, which means I'm going to take a second to put some more water into my cup because I need water. Give me a hot sec. 2 seconds, y'all. But look at this table. It's important. Or picture, rather. Okay, I'm back. Hello again. Sorry, I just need more water. I was like getting parched. But okay. So, for the dosing strategies for like different kinds of heparin, for low dose prophylaxis, it's all going to be sub-Q. It's all going to be sub-Q. For continuous IV, there's a pump for that shit. You don't have to deal with it. Like low key, you do not have to deal with it. Just pumps. But what was I saying? So. Yep. The picture I showed you guys, that's for unfractionated heparin because it is an indirect inhibitor of factor 10A because of the potentiation of antithrombin 3, which inhibits factor 10A, which means decreased activation of prothrombin, which means decreased thrombin, and decreased fibrinogen activation, which means decreased fibrin, but has a shorter half-life. I already mentioned that. The low molecular weight heparins and the synthetic heparin, so like fondaparinux, or fondaparinux, I do not know how to pronounce it. I'll ask somebody later. It has higher bioavailability than unfractionated heparin, and it has a longer half-life, so it's 2 to 4 times longer than unfractionated heparin. For direct thrombin inhibitors, it's just going to go straight to 10A, and it acts independently from antithrombin. That's how that works, basically. For adverse effects, the general side effects are going to be bleeding, but there's going to be specific drug-drug interactions. But the significant bleeding risk is like the main side effect of all anticoagulants, because obviously you're going to have to contend with that. You're going to have to contend with the bleeding risk when you're giving someone a goddamn anticoagulant. Like, you're literally thinning their blood. You're going to make it easier for them to bleed. Think about that when you're doing it, obviously. But for the specific side effects, for unfractionated and low molecular weight, you are going to have allergic reactions, and there's going to be increased risk of heparin-induced thrombocytopenia. There's also going to be increased risk of osteoporosis. This is because of the increased osteoclastic activity, but there's also the decreased production of calcitriol is another. But the decreased production of calcitriol is another potential cause of the osteoporosis. But the osteoporosis associated with unfractionated and low molecular weight heparin is dose dependent. And like use for like long-term therapy, you switch them onto like an oral anticoagulant. It's also gonna be more feasible that way for them, like low-key from what I've seen. Nobody fucking likes doing sub-Q injections unless it's for like Ozempic. And even then, people don't like doing it, and they're just gonna come into the clinic and then have us do it. I have done so many sub-Q injections of Ozempic for other people. And also their IM gluteal injections for testosterone. I've done people's injections for work so many times. It's actually, like, weirdly enough, one of my favorite things to do. I'm very good at it. I like giving injections at work. It's very fun. I really hope I'm not offline. But okay. Can't believe the talk of injections made people leave. That's funny. But okay. Now we're going to go on to synthetic heparin. For synthetic heparin, one of the main side effects is going to be an occasionally low platelet count. That's going to be important. Heparinoids, though, you're going to have... This is rare. Extremely rare, but there's going to be asthma exacerbation. But for direct thrombin inhibitors, you can have allergies or fever. That can happen. And then for thrombocytopenia, the treatment with heparin can cause... So treatment with heparin, especially unfractionated heparin, can cause thrombocytopenia. This may be immune mediated. This is formerly known as type 2 HIT, or non-immune heparin associated thrombocytopenia, which is the formerly known as type 1. The alternate diagnosis. So I'm going to give you the for heparin-induced thrombocytopenia. We're going to yap about that in a second, but we're just going to first go into the indications for heparin use. Okay? Ready? Awesome. Cool. So, for the indications for heparin, we're going to first go on to unfractionated heparin. Look at the table again. Where is that? You already know. It's going to be on AT. It's going to be on the antithrombin 3, and also going to be on the factor 10A, because it's going to go from AT3 onto thrombin 2A. Remember? Okay, cool. Unfractionated heparin. For low-dose therapy, this is for VTE prophylaxis. VTE is going to be VTE is basically thrombosis embolism, like the deep vein the venous thromboembolism. Sorry. This is an umbrella term that encompasses DVT and PE. But yeah, to prevent a VTE happening... Oh no! I just dropped my lid of my water. It's fine, nothing spilled, but still. Low-dose unfractionated heparin is for VTE prophylaxis. High-dose therapy, though, this is for the acute treatment. This is for the treatment of acute DVT, acute pulmonary embolism, acute coronary syndrome, acute arterial thrombosis, or prophylaxis of VTE for patients during hemodialysis, ECMO, mechanical heart valve replacement, or AFib. Low molecular weight heparin is for the treatment of acute DVT as well. But the difference for low molecular weight heparin is that it can also be used to treat unstable angina, non-ST elevation, acute coronary syndrome, or STEMI in patients undergoing fibrinolysis. It's also for VTE as well, but oh, hello. How are you doing? Hi, Hema. Also, wait, Hema, question. Wait, I forgot the question already. Never mind. Yeah, is it factor 5 lighting that you had? I forgot. We're gonna do Q Bank though, I promise. I'm just gonna have to go through. I'm still not done talking about this though. But like once I'm done talking about it, we do in Q Bank. Okay. Okay. Give me like 2 seconds to finish what I'm talking about so I can be done with it. And then we can. Prophylaxis for VTE, stent thrombosis in patients undergoing percutaneous coronary intervention, and stroke in patients with AFib undergoing cardioversion. But the reason why I'm talking about this, okay, factor V, okay. Okay, cool. Go shower, dude. Come on. Be a human. Contraindications are in recent stroke, uncontrolled hypertension, active bleeding, or HIT, except for direct thrombin inhibitors, which can be used for anticoagulation in HIT. Special patient groups. Unfractionated heparin and low molecular weight heparin can be used in pregnancy because neither cross the placenta nor are they transferred through breast milk, but low molecular weight heparin has fewer side effects. But okay, let's do some Q-Bang after like Hima's back from the shower. Hika, I think Hika's working radiology today, or like he's always working radiology, but like I think that's where he is right now. It's either that or he's sleeping, because it's like I don't know what time zone it is for him. That's like my always been my question. I have always wondered. But Dr. Kira MD came in here a little bit ago. You missed her. She is another Dr. VTuber. She just came in to like say hi while she was working. She's working in the ED today, or she works ED. Okay, we are gonna do Q Bank though. Q Bank. New custom session, or should I do a study plan? But yeah, we're gonna do Q Bank now. Oh, we're just gonna do a quick 40 questions. Quick, I say, because like I wanted to like finish up with like anticoagulants today. But okay, here's our first question. 73-year-old woman is brought to the physician by your son because of increased forgetfulness over the past 2 years. Initially, she used to misplace keys or her dog's name or her phone number, but she often forgets now about what she's seen on television or read about the day before. She used to go on a walk every month, but she stopped 1 month ago after she got lost on her way home. Her son has prevented her from cooking because she has episodes of leaving the gas on after cooking a meal. She becomes agitated when asking questions, but is unconcerned when her patient reports her history and says that he is overprotective of her. She is on aspirin, enalapril, carvedilol, and atorvastatin. She is alert and oriented to person and place, but not to time. Short and long-term memory deficits are present. Impaired while she Huh. Hey, Hika. Question for you, buddy. She has like she's 72. She has hypertension, coronary arteries disease, and hypercholesteremia. Vital signs are within normal limits. Clock drawing is impaired. She draws 14 numbers. Would this be vascular dementia? What? Oh. Wait. That wasn't. Oh, vascular dementia is stepwise. This is slower progressive. Okay. Yeah, I thought so too. I was like, could this be vascular? I guess not. It was not vascular after all. Look, that's what I thought it was initially. Because that's what made sense to me. So this man has acute Hep B infection. Or 9 months ago, he was diagnosed with acute Hep B. Physical exam shows no abnormalities. Serum studies show increased hepatic transaminase activity and hepatic B viral load of 4286. Oh. Oh, yeah. Oh, God. What the hell? No. Okay. Oh, I didn't know it would do that. So is it going to be... What is this? What does this mean? So, like, if he has a Hep B viral load... Oh. What do you mean? How did you read the colon wrong? I think we read it the same way. Oh, surface antigen negative. Okay. Oh my god, why are you doing this to me, AMBOSS? Stop flicking me, man. Fuck you. And that's gonna be this. This. So it's gonna be B, D, E, F. Okay. So then... Anti-HU. Wouldn't it be IgM? Because he no longer has active infection. Wouldn't it be A? Because like he has it chronically now. For like... Right? Okay, so we're thinking the same way. Oh! Really? HBV DNA would be undetectable in patients who recover completely. So, okay. I mean, that... Because I was like, this makes sense. Oh, wait! This had negative. HBE negative. Yeah, no, that wouldn't make sense. It's probably E. Yeah, I agree with... Okay, I was like, F makes sense. Oh, it was E. Okay. Oh, surface would be positive, anti-HB would be negative, but HBAG would be positive. Okay, that makes more sense now. That makes more sense. I get it now.
Did it not throw? Oh, it did. Okay, cool.
Yeah, I was like, wait, you read it right the first time. Because, like, that's how I read it too. If you read it wrong, then I read it wrong. I mean, it is likely for me to read it wrong because I don't know how to read, but, like, still. I like knowing how to read, but sometimes I just don't know. Okay. 60-year-old man comes to the physician because of a 6-month history of a painless ulcer on the neck. Wait. 1 second. So which one is the... 1 minute. Let me see the attending tip. Huh. Oh. Okay, that makes more sense now. I don't know, buddy. Crohn's disease. Oh. UV light exposure. This is UV light exposure. HBAG surface? Oh, yeah, then I did not read it right. You read it right the first time. I did not read it right at all. I thought the surface was S. You know, because, like, that's what makes sense, right? Right? That's what makes sense to me. Yeah, and it's UV. This is SCC. She doesn't smoke or drink alcohol or take meds. Okay, good for her. Wow, boring. This is pustules over the throat and upper thighs. Hair follicles? This is like hot tub. This is a hot tub thing. Do you remember what that's called? Like the hot tub thing with like Sudi aeruginosa or something? I think it's Pseudomonas. Because she was at a hotel with like she was at a hotel resort with swimming pools and like whirlpools. That's Pseudomonas. That's like one of those. It's like hot tub disease. Hot tub disease. Thank you. Hot tub folliculitis. Thank you. Thank you. Thank you. That's the one I was thinking of. Thank you so much. That is literally what I was looking at. I was thinking of. I was like, this is a hot tub thing. Like Sudi aeruginosa. Okay. Appears well, vitals within normal limits. Physical exam shows tenderness to palpation of the lower spine. Both knees are enlarged and swollen. Neurologic examination shows bilateral sensory neural hearing impairment. I don't know this at all. It is? Oh shit. I didn't realize. Sorry. I don't know why. Like, everything is working on my end. Again. Maybe it's my internet again. It was working well yesterday, though, so I don't know what's up today. I don't fucking know anymore. Low-key. GGT is 30. Serum calcium is 10.2. But yeah, on the laggy part, I have no clue how to fix that. Huh? Yes, 30 is normal.